Today is a Stanford 25 session, and we're talking about Pulsus paradoxus. I always like this one, among other reasons, because it's actually, as we'll see, something we can recreate in a normal individual to be able to learn how to do well. And number two is that it's actually a really clinically useful skill to know. It's not just a theoretical one, but one that can actually make a big difference in your care of patients. Pulsus paradoxus, it's a drop in your systolic blood pressure greater than expected with inspiration. The term's a bad one because it implies, paradoxus implies it's sort of the opposite of what you'd expect. It's not opposite, it's just an exaggeration of a normal physiologic effect. So in all of us, when we inhale, for reasons we'll get to in a second, you will have a small drop in your systolic blood pressure. That's normal, but it's normally just a few millimeters of mercury. For Pulsus paradoxus, it is a very exaggerated one. And yes, as was noted, when 10 millimeters of mercury is typically the threshold where we'll say this is abnormal. Okay. All right, so that's what it is. Let's talk about the mechanisms of it. So again, I wrote in shorthand what it is. And so what happens to the pressure in the intrathoracic cavity? Goes down, right? Okay. So the key point here is that it is dropping in the intrathoracic cavity, but not outside the intrathoracic cavity. So the dotted line I've shown, by the way, not to scale. Okay. All right. In case you thought it was. So the dotted line here is the pericardium. The intrathoracic cavity is obviously bigger than the pericardial space. So if we think about venous return, you're taking a deep breath in, you're making it more negative in the right atrium. What's going to happen to venous return? It's going to increase because the pressure gradient from the veins outside of the intrathoracic cavity, now you have a bigger gradient because it's more negative inside the thorax. So blood is coming in here, okay? Makes its way to the right ventricle. Now, normally in you and me, what does the right ventricle do to accommodate that extra blood? I mean, it gets bigger, but in what direction?
Towards the LV.
No, no. Normally, it just, because the LV is this big pressure sac here, so the septum doesn't want to move. So it just comes out this way. It doesn't really affect the LV very much, maybe a tiny bit, but not very much. And that's why, because this is the biggest mechanism for Pulsus paradoxus, that's why you don't tend to have a big drop in your systemic blood pressure, because the RV is just accommodating the blood going this way. Okay. Now imagine the classic case, you have tamponade. And you have a high intrapericardial pressure that's going to prevent us from having the RV go out this way. So now what happens to the septum? Now it bows into the LV. Okay, and so it bows into the LV. You have less LV filling. You have less of a pulse pressure. You have a lower systolic blood pressure. Okay, so that's the main mechanism behind Pulsus paradoxus. Now, this is the case in tamponade, which is the typical thing that we're trying to evaluate when we're looking at a Pulsus paradoxus. I want to say a word about constriction because the mechanism's a little different and it's not as reliable that you'll have a Pulsus. So tamponade, what is filling that intrapericardial space?
Fluid or what?
Right, some form of fluid, and it's okay. So in constriction, though, that's not it. So what's preventing relaxation in constriction?
The pericardium itself.
That's right. That's right. So the pericardium itself is stiff, usually calcified. There's a number of different causes, but for whatever the cause, radiation or tuberculosis or whatever it might be, but you have a past cardiac surgery, but you have a stiff, non-compliant pericardium that is physically preventing the ventricle from relaxing. Well, the tricky thing in classic constriction is that imagine you have this very calcified pericardium. It's just a shell. When you take a breath in, that pressure is not actually transmitting across the pericardium because it's a shell. And so the usual impact that would be causing this increased venous return never happens because that negative intrathoracic pressure isn't getting transmitted to the RA and therefore increasing venous return. And yet you can still get a Pulsus in constriction. So why is that? Well, one, this isn't a perfect thing, and probably a little bit of that pressure does, negative pressure does get across, so you get a little bit of that. But the other part is that the pulmonary veins, which are returning blood to the left atrium, are inside the thorax, but outside the pericardium, right? So now you're taking a breath in, you're dropping the pressure in the pulmonary veins, okay? You're not changing anything in here. How is that going to change the filling of the left side? It's going to decrease it. So same thing happens. You're breathing in, and you are dropping the filling of the left side, and you get decreased pulse pressure, right? You wouldn't see this in tamponade, because in tamponade, that drop here is also transmitted here. So that doesn't have the effect here. So this is what causes it primarily in constriction, is the effect on the pulmonary veins. Whereas for tamponade, it is because of venous return to the right side. Make sense, everybody? Okay. All right, so that's the basics. Okay, so why do we care? Well, because pericardial effusions you'll see with a decent amount of frequency, and the question with a pericardial effusion is always, does it have hemodynamic significance, right? And because do you need to drain it or not? And so, how do we know that? Well, first of all, repeat after me. Tamponade is a clinical diagnosis. So this is actually really true. This is one of those aphorisms that's true. So, so if a person comes in with a big pericardial effusion, or big enough, and for no other good reason, they've got a small pulse pressure and they're tachycardic and they feel bad, it's probably tamponade. But that being said, a lot of the times it's kind of borderline, or you're just not sure and you're trying to get a sense. Or the person comes in the ER and they're short of breath and you do an echo and you see there's some effusion and you're like, do we need to call the cath lab tonight to come in to drain this, or can this wait? Okay, so Pulsus paradoxus can be really useful for this. Okay, so how to physically do, and then after we go through this, then I see Sulaiman found a nice short sleeve shirt as our model. Awesome. So I will show you how we will create a Pulsus first in Sulaiman and then in all of you. And we'll demonstrate how to do it. And everybody, that's why we got blood pressure cuffs, so everybody's going to walk out of here hopefully comfortable in measuring it. Okay, so what you're trying to do, so this is pressure time. Okay, so this is what it's looking like, right? So this is, somebody is exhaling, somebody is inhaling. Okay, smaller pulse pressure, small. So what you're trying to detect when you say their pulsus is such and such, you're trying to detect what is the difference in these two numbers. Okay, so if this is greater than 10, now you would consider it significant, 10 millimeters of mercury. All right, so how to measure that? Well, you inflate a cuff above this level, just as you would for taking anyone's blood pressure, and you gradually release it. And once you get to this, what are you going to hear? Yeah, first core cough sound, so you'll hear. But so normally, let's say somebody's heart rate was, normal heart rate, you'd hear, right, with their heartbeat. But what happens here? Well, right when you get just below this sound, you're going to hear this, but you're not going to hear that. Okay, now I've drawn this as if every other beat is different. The truth is, let me draw this more appropriately, because people aren't breathing with every heartbeat, obviously, so it's going to go more like this. Okay, and so we're, again, talking about the difference between here and here. So what if you are kind of right around there on your cuff? Well, you're going to hear, right, so the sound is going to be loud here, maybe barely audible there, and then it's going to disappear until you get back above that. Okay, so how to do it? You get above the pressure, you start going down on the cuff until you get right here, and that is the first number that you note. So let's say it's 118. And now you got to go really slowly. And then how do you know you're here? What are you hearing?
It's constant. Pathophysiology.
Constant meaning what?
Like it wouldn't like get softer. Like
Yeah, you'll hear it every beat,
yeah.
right? So the difference between hearing the very first sound and then you're hearing it every heartbeats, that's the difference. That's what you're measuring, okay? And it's that simple. Okay, so a few rules, and then we're going to demonstrate them. What I'll do. So, number one, I'd say the number one mistake I see when people try to do this is that they're trying to look at the reading on the cuff, and they're trying to watch the person's breathing to try to sort of correlate it. Well, hold on, they're breathing right now. It should be higher. Okay. Good rule: people will breathe. Okay, so as long as you don't have them hold their breath, and there's no reason to have them hold their breath, they will breathe. So just go slowly, and as long as you're going slowly, you'll catch it in different phases of respiration. Okay, so don't even look at the breathing. Number two, I got at this. You got to go down slowly, because if just between beats you're dropping a few millimeters of mercury, then you're throwing way too much air in this. So sometimes, like, you don't even know where it's going to start, so you can pump it up to whatever, 180. You can come down quickly, kind of just to get a sense of around where it is that you're going to be looking at. And then you start hearing something around 120, great. Now you pump it back up, and now go really slowly as you go between that. Because again, these are the two numbers that we need, okay? Number three, if a person happens to have an A line in, they're in the ICU with an A line, well, I hate to say it because this is a physical exam session, but you don't really need to do it if they have an A line in. You can just look at the A line, and you'll see a pulsus on people with an A line not that infrequently if they have the right situation for it. So then use it. Even a sat monitor you can get a sense from. Because remember, a sat monitor is a poor person's A line, basically. And so you can see in somebody with quite prominent pulsus, you'll see that get smaller, bigger and smaller with the respiratory cycle. Again, that you're not going to be able to get a number off of. The A line, you can actually measure the pressure, but you can use the sat monitor. Okay. Number four, the rhythm must be regular. If somebody has an irregular rhythm, they're in AFib, or they're having ectopy all over the place, forget it, this doesn't work, right? Because now, if you have an irregular rhythm, the ventricle is going to be more or less full, dependent on how big the RR interval is. So you cannot measure a pulsus in somebody without a regular rhythm, okay? And then number five, if you are comfortable measuring a pulsus, which hopefully everybody will be as we finish this session, then you don't, ordering that echo to say, is there hemodynamic effect or hemodynamic compromise, it's actually not that important, because what they're looking at by echo is basically what you're measuring with pulsus. And in fact, one of the things that they look at when you're looking for hemodynamic effects is directly trying to look at the velocity of blood across the mitral valve as a surrogate for filling the left ventricle and stroke volume. Well, that's exactly what you're measuring the effect of when you're measuring a pulsus. So again, this is not just a parlor trick that you can pull out to impress people. This is actually quite clinically relevant if you have a person with a pericardial effusion and you're trying to get a sense of, is it tamponade or not? Do we need to send this person for drainage or not? Person with constriction or with tamponade, what you're looking for, on an echo, they'll turn on the respirometer. This is on a formal echo, you can't do this on a pulsus, but you'll turn on the respirometer and you can see the septum shift. Not shift because it's contracting, but shift because of the respiratory cycle. So you can look for that, but that's all you can look for. Okay, so I'm going to create a hemopericardium in Sulaiman. That wouldn't work. So how are we going to create a pulsus in PS to be able to demonstrate this? The thing that somebody can, an actual medical condition people can have, or an exacerbation that can cause it. Anybody know? Asthma, that's right. So like status medicus would be kind of a classic. And it's because what you're taking advantage of is causing the extreme negative intrathoracic pressures that you're getting with that. And so what you're largely, there's two parts that you're seeing with that. One is that exaggeration of the normal hemodynamic effect, again, of the differences in filling with respiration. So that's a big part of it. There's a secondary part which is getting at when you're creating that much negative intrathoracic pressure, even though it's not actually changing the flow out of the aorta, it is dropping the pressure in the heart and the proximal aorta, which ultimately gets transmitted elsewhere because you're dropping all the pressure so much. So you're not creating a pressure gradient, but you are changing the pressure. So what it can look like in somebody with asthma, as opposed to this, is, draw this better. So you'll note that the pulse pressure isn't getting smaller, but because of the effects dropping the pressure going up and down with inspiration, the pulse pressure is the same, but the actual pressure itself is smaller. This mechanism is less important because it doesn't have it doesn't have so much physiologic relevance, but it's something we can take advantage of in terms of creating a pulsus. And again, we're looking for the difference between those two. So what you'll note with a straw, so let's have you breathe out, not in first, okay? And take your other hand, don't put it literally, don't occlude flow, but put it up so you can feel the flow, okay? And you can start blowing softly, and then start blowing harder, and then harder and harder and harder. And what you'll see is you pretty quickly get to a maximum you can get to, and you can't get any higher than that. You're just going to turn your face red, right? So this, by the way, is a good example of why in critical aortic stenosis you can't increase your cardiac output, because it doesn't matter how much force you have behind it, the size of the hole and the properties of air, or the size of the hole and the properties of blood, if you're talking about out of the aortic valve, will limit the flow. So good example for that. What we're taking advantage of here is you're creating all this extra resistance as you're breathing in, and so if you really exaggerate, I'm about to pass out, if you really exaggerate and with your breathing in, you really use as much force as you can, and then as you're breathing out, you use as much force as you can actually really create a big exaggerated effect on the intrathoracic pressure, and should be able to measure a pulsus. Okay, so you see when he's breathing out, we can hear it. Goes away when he's breathing in. Now he's breathing out, we can hear it. Now it goes away when he's breathing in, right? So let's see how high when he's breathing out. Still hear it here, right? Now breathe in, and it goes away, right? Let's see if you're going to pass out, stop. Now I've gone up to 150. We can still hear it when he's breathing in, but not. Just hear it here when he's breathing in, right? But not when he's, so it's right around 150. Now I'm going to go down. Breathing out. Pretty much gone when he's breathing in, so we got to go lower. Still not really here when he's breathing in. Boy, it's still pretty much, okay, I may stop here before Sulaiman passes out, but
feel good.
You feel good? Okay, keep going. I don't want to be responsible for. Now he's breathing out. Okay, we can hear it every beat here now, right? So it was somewhere in the 150 or so was when we first started hearing it, and somewhere in maybe the 100 to 110 when he's not. Should we give a round of applause to Sulaiman? All right. So for Sulaiman, when we were checking his pulsus, what we saw was that when he was doing the exaggerated exhalation, and now we are having less blood flow to the right side of the heart because he has positive intrathoracic pressure impeding flow, and therefore the septum is more bowing this direction. What we're seeing is that he has more filling to the left side, and he's getting increased pulse pressure, and that's when he's reaching his peak blood pressure, and he got up to right around 150. Now, we checked his blood pressure before starting, and his normal blood pressure is actually about 120, nice and healthy, I'm happy to say. But this is the exaggerated effect and more filling of the LV. As we then came down, I should say, as he started inhaling, and now he's creating really tremendous negative intrathoracic pressure because he's doing it through the straw, now you're suddenly having the rush of blood into the right side, relative underfilling of the left ventricle, and now we only hear sounds when we're somewhere between 100 and 110 millimeters of mercury, and so let's just say it was about 105. So now we have what we have had Sulaiman artificially create is a 45 millimeter of mercury pulsus. So again, in this case, he's nice and healthy. We're creating this as an exaggerated effect. But if you saw this in a patient with a pericardial effusion, this would be a great reason for worry that it's tamponade.